A very warm good evening to everyone. As we all know, you all know, today's topic is Ayurvedic management of common dermatological disorders and overview. It's myself, Dr. Arun Kumarji. Thanks for a good introduction. So we can directly enter to the topic. In between, if you are getting any doubts, we can stop and we can have a discussion also. Is it okay? So the common diseases in dermatology coming in our general practice include infections, eczemas, papilloscomas disorders, Bullous disorders, pigmentary disorders, and diseases affecting appendageal like affecting disorders. Then skin diseases as a part of systemic diseases and STDs and HIV. So infections we all know include bacterial, fungal, viral, and parasitic infections. Those we will be discussing in our next slides. Then eczemas we all know include external eczemas like contact dermatitis and internal eczemas like atopic dermatitis. Dermatitis, stasis, eczemas, etc. Then papilloscomas, we all know that it include papilloscomas lesions like psoriasis, lichen planus, etc. Then vesicular bullous disorders, we all know it include chickenpox, scabies, bullous pemphigoid, like herpes, like lesions. Then pigmentary disorders are there like vitiligo, leukoderma, melasma, like lesions. Then appendage disorders are there. These are the lesions affecting hair like alopecia. Then nail lesions are there. Then acne like lesions affecting sebaceous glands and all. Then we all know those manifestations of skin as a part of internal diseases like acanthosis nigricans. We can see in the case of systemic diseases like diabetes, dyslipidemia, etc. Then in Graves' disease and all, there will be skin manifestations. Then STDs and HIVs. So we all know these conditions in Ayurveda are mentioned in various portions. Okay, we can't see in a single entity itself all these skin lesions available. So some lesions are mentioned in the context of Kushtaroga, some in Visarpa, Vadashonita, Pitaka, and Pityriasism. Vitiligo like lesions will be will be seen in Sutra. Then ulcers will be in Prana, Shudra Rogas, so many conditions are mentioned. In Shirorogas, alopecia like conditions are mentioned. Then allergic manifestations can be seen in Shidavita and Udarta context. Then Agandu Jara cases, also acute manifestations can be dealt in that context. Then insect bites and all in the case of Vishachitsa. So what is the importance of DOSHIC identification here? Most of the time we will be getting patients after taking so many treatments. So what happens in those cases, patient will be approaching us without the primary lesion morphology of the lesion. Okay, so they will be losing that primary morphology of the lesion. So it will be very difficult to make a definite diagnosis of the case. And in our science also, there is no specific remedies are mentioned for a specific disease. For example, if you are taking Jivandyadi Yamaga mentioned in Ashtangar, Chikilsasthana, Pushta Prakarana, actually it is mentioned for all Vantagapa conditions like Charma, Ega, Pidiba, Sidma, Alasa, Vibadiga, like that. So it's not mentioned for a single entity of disease. It's mentioned for a broad spectrum of disease having Vantagapa predominance. Okay. And most of the time, Dosha Vividita approach will not be that much suitable. For example, if you consider a Vijarchika, okay, Vijarchika means it will be Lesigardia. As per our test, it is Lesigardia. Okay, the Lesigardia means with discharge, that lesion will be acute, in acute stage only. Meaning, if you are considering or comparing Vijarchika with eczema, in the acute stage of eczema only we can compare Vijarchika with eczema. Okay, when that eczema turns to a chronic stage, it will become Vata predominant and it will lose its exudates. Okay, internally there will be definitely spongiotic changes will be there. Okay, but externally exudates will not be seen. So in that stage, in that chronic stage, we have to administer some Vata predominant medicines, not Pitta predominant. So in a single disease entity itself, instead of giving Vyadhi Viparita approach, we have to give more importance to Dosha Viparita approach. That will be more ideal. But at the same time, the modern diagnosing the case, okay, present before us is also very important, because to make a healthy interaction with the patient, we should convey him or her what is the condition is. Okay, so we should have, we should know the modern diagnosis and we should convey it, and also the Ayurvedic inference also we have to make. Okay. And for proper prognosis and for planning proper duration of the treatment, for that also modern diagnosis is important. We all know chronic cases like lichen planus, psoriasis, pemphigus like diseases is very difficult to cure. Okay, so its prognosis is not that much good, and also it need a longer intervention. Okay, so for planning that duration of the treatment, what is the condition? Okay, what is the nature of the lesion and what is the that disease, that we should know, and then only we can properly plan that duration, and also we can convey the prognosis of the disease to the patient. And for removal of the cause also, for removal of the aggravating factors also, this modern diagnosis is important. For example, in the case of contact dermatitis, if footwear dermatitis patient is appearing before us, it is very important, along with that medication, it is very important to advise them to avoid that footwear that is causing irritation to the skin. Okay, so for removing the causative or aggravating factors, for that also modern diagnosis is very important. Considering the Samprapthi, okay, the major, the key points of the Ayurvedic Kushta Samprapthi are, there will be in every in cases of Kushta, there will be Kapha and Peda accumulation first. Okay, and in the Kleda accumulated Kapha predominant stage, when there is a vitiation of Pitta and or Rakta vitiation, there happens the manifestation of the skin disease. Okay, so what happens is, after the Dosha Dushti, there will be Dhatu Dushti, and as per the involvement of the Dhatu, there will be symptoms will be appearing. Okay, and as we all know in our classics, Tok, Lesiga, Asar, Amisha are the mentioned Dhadus in our classics. And in Chakramani commentary and all, it is mentioned that if the Pitta is in a very aggravated form, okay, if the Pitta Vruddhi is much more, there will be spreading. Okay, the Visarpana nature, the spreading nature of the disease will be, the acuteness of the disease will be more. Okay, when the Pitta is Manda, the Visarpana or spreading nature will be much less. Okay. So in each and every skin disease, we have to assess the dosha dushti, we have to consider the dhatu involved, we have to assess the presence of ama and also the stage of pitta. Stage of pitta we already mentioned, if in a rapidly spreading, rapidly progressing disease, the pitta will be in a very aggravated form, whereas in a manda, means slowly progressing disease, pitta will not be that much. Okay, vitiation, pitta vitiation will not be that much. Okay, and the presence of ama, we all know, we can identify by using Upashaya, okay, Upashaya and Upashaya method. As per our Acharya also, in the context of Jara, it is mentioned in the Navajara, Kashaya, the Kashaya preparations are not indicated. Okay, so that is supposed to mean, that same case is admissible in the case of acute nature of also. Okay, so in a case of skin disease where ama is there, when we administer a kashaya, what happens is it will aggravate. Okay, so when on administration of a kashaya, if the lesions is increasing, means there is much amount of ama is there. So we have to give some. Amapajana and Devana drugs. What happens is if the vishation of ama is that much heavy, we have to give some Sramsana drugs first. Okay. What happens is on giving that Sramsana drug, some quantity of ama present in Koshta will get eliminated, and the remaining present in Srotas and Dhadus can be decrease can be cured by using Pajana drugs and Devana drugs. Then later on by using Srodha Shodhana drugs. Okay. Next slide. In next slide, we can see how to assess the dosha dushti and dhatu dushti. This slide shows one dosha assessment tool. In a vada predominant lesion, there will be dryness will be there, thin scales will be there, then pain, okay, ruja will be there, then the lesion will be rough or parusha, okay, and then spreading nature will be there, then blackishness will be there, then the lesion will be chronic, then dry itch, okay. We all know that dry itching is a feature of kapha, okay. In the case of like in simplest chronicus and all, there will be much itching, okay. In the lichen planus and all, there will be much itching. Actually, that kind of itching can be attributed to kapha predominance. But in the case of atopic dermatitis, okay, that is Bala Visarpa. In Bala Visarpa also there will be much itching. Okay, patient, the main complaint will be itching itself. Itching. There will be thickening, lichenification of the lesion, like that. Okay. So in that like atopic dermatitis cases, if you are giving some Kabahara drug, the itching will be we can see that itching will be aggravating. So in that case, we have to do some in external Vadagna drug, some oleation treatment. Okay, oleation treatment that cause no aggravation of Pitta. At the same time, curing Vada like that, drugs we have to administer. So in the case of atopic dermatitis, the itching present is dry itch. Okay, that can be attributed to Vada dosha. Okay, and the scales, thin scales, we can see in the case of PITYRIASIS versicolor conditions. We can see there will be thin scales. Okay, that also we can attribute to Vada aggravation. Okay, and the case of Pitta, there will be erythema. We all know that erythema is a classical feature of Pitta. Then suppuration will be there, oozing will be there, burning will be there. Then visarpana, spreading nature is also attributed to Pitta also. Then there will be lymphadenopathy. Okay. If you any secondary infection is happening along on footwear dermatitis, footwear eczema, there will be definitely lymphadenopathy. Okay, then in impetigo cases also chances of lymphadenopathy is there. So lymphadenopathy is a symbol of inflammation. Okay.
Sir,
hello.
Sir, 1 second. Somebody is there in. Can you please admit the participants? I can't do it.
Oh, okay. Admit all. Is it?
Yes, yes.
Can you audible clearly?
Yes.
Yes. Okay. Thank you. So fever, with fever, if the lesion is happening along with fever, that also is a feature of Pitta. And then in the case of Kapha, we can assess the aggravation of Kapha by virtue of itching, then chronicity of the lesion, then oozing. Okay, we already discussed can be attributed to Pitta and Kapha. Okay, then hard lesion. Okay, thick hard lesion. That can be due to hyperkeratinization. On touching itself, we can feel that hardness of the lesion. Then lichenification means the lesion will be thick. Along with that, there will be skin markings. So lichenification is also a feature of kapha aggravation. Then whitish lesion, then feverishness. Okay, Shida Okay, Shida Juram. That there will be the feverishness feeling will be there for patient. That also can be attributed to kapha aggravation. Then hard scales. Hard scales in the case of plague psoriasis and all will be getting hard scale. That can be attributed to kapha aggravation. So this slide is showing some dosha assessment tool. Now, coming to Dhatu vitiation, as we already mentioned, so Lesika, Asrak, and Amisha are the main Dhatus as per classic. So if Tok and Lesika only is involved, there will be some discoloration only. Okay, discoloration. There will not be any eruption. Okay. So discoloration means there will be macules only will be present. Okay. If recta is involved, there will be pitaka.
Sir, hello, sir. Hello. Hello, sir. Erosions and involvement. And we all know, regarding primary and secondary skin lesions. Actually, what is the importance of in these skin lesions? Knowing these primary and secondary lesion is that most of the time the patient will be its morphology. So it is very difficult to make a conclusive diagnosis in the first visit itself. Okay, clinically. Okay, so at that time it is better to describe the patient's condition with the primary or secondary lesion. So in primary lesions, we all know macule means only discoloration is there. Papule means hard elevation. In the case of papule, it's a hard eruption. Its size is mentioned in some textbook as up to half centimeter and centimeter. And large papules are called nodule, and basically is fluid filled. Okay, and that also half centimeter is mentioned in size in some textbook, and in some textbook as 1 centimeter also. Bullae are large vesicles. Then pustule means pus filled. Okay, burrow we can see in the case of scabies and all, there will be burrows. Wheel we can see in the case of urticaria and all, there will be wheel as primary lesion. Plague means the height will be less. It's more or less a flat lesion. Can be seen in the case of lichen planus, psoriasis, etc. That kind of lesions, primary lesions. Secondary lesions means there will be involvement of external factors. Okay, like wind, hotness, humidity, scratching, etc. So scale, in psoriasis and all, there will be scale. Crust means the exudate will be. In the case of eczemas, it will be seen. In case of impetigo and all, as a part of post-inflammatory scar will be there. Then fissure in the case of plantar psoriasis and all, there will be fissures on hand and foot. Erosion means there will be loss of superficial epidermis of the skin, whereas ulcer means there will be loss of also. Then lichenification, and in that what happens is there will be thickening of the skin, and the skin markings will be prominent. Okay, this lichenification can be seen in the case of lichen simplex chronicus, atopic dermatitis, like in all these. Now, we can go to specific, cases. Okay, first of all, fungal infections.
Here we will be dealing with the superficial fungal infections. In the superficial fungal infections, most important one are dermatophytosis. Okay, dermatophytosis we all know caused by three types of fungi: microsporum, epidermophyton, and trichophyton. Now, of these, trichophyton infect skin, nail, and hair. Okay, whereas microsporum does not infect nail, and epidermophyton does not infect hair. Okay, so these three group of fungus have got much affinity for keratin. Okay, keratin present in the external layer of the skin, and mostly they are coming exhibiting as round lesions, so they are called ringworm also. And as per the site affected, their morphology and their nomenclature also differs. Okay, so you know, scalp, when they affect scalp, this is called Tinea Pedis. When they affect glabrous skin, it is called Tinea corporis. When they affect the gluteal cleft and groin, it is called Tinea cruris, like that. So tinea corporis mean tinea affecting the normal skin. So in this picture itself, we can see the features. The external border will be active, the internal portion will be inactive. Okay, in this case, internal some lesions are also present, mostly due to application of some topical steroid. Okay, in if usually what happens is the patient will be purchasing over the counter some topical steroids and all, and they will be trying their own treatment. Okay, after all, only they will be reaching to us. So in that cases also, what happens is there will be some loss of the distinct morphology. Okay, actually the feature of the tinea corporis is that the external area will be active and the central will be clearing. Okay, and microscopic examination of scrapings, potassium hydroxide in potassium hydroxide solution will make the diagnosis. It can be considered under Dadru. Okay, in our textbook, Dadru Sakandu Ragapadam, Dadru Mandala Pukadam is mentioned. Also, the Pradana Durbava Muchi Usana Mandala Dadru, Kandumadi and Shankani is mentioned. Why I am quoting this quotation here is that actually when we consider both conditions, okay, we can see that Charakajarya actually mentioned Dadru as a Shudra Gushta, whereas Atanga and Susruda mentioned it as a Mahakushta. And in that features also we can see in Charaga it is mentioned as Raga Pedaga, like color is mentioned as reddish. Okay, actually we can see those tinea which is very new in origin. Okay, which is not chronic, will be somewhat reddish, and it is if we are administering medicine at that stage itself, it is very easy to cure. Whereas those having blackish or bluish like chronic lesions, it is very difficult to cure. It's a chronic. That may be the reason why Ashtanga Hridayagara and Susracharya mentioned it as Anshankani and considered it as a Mahakushta. Okay, then tinea cruris that affecting on the gluteal cleft and groin. Okay. And here, we can consider compared to Ushnagachu and Dedru. Then Tinea capitis is there. One thing we have to keep it in mind is that Tinea capitis means the dermatophytic infection of the scalp. But what happens is actually this one is not seen in developed countries and all. In developing countries, these kind of lesions are much more. And here also what we are getting is in adults and all, Tinea capitis is not that much prevalent. Usually tinea capitis is happening more in children and also in immunocompromised person. Okay, and three kinds of tinea capitis are there: Favus, Carrion, and black dot. In Favus, what happens is there will be scarring alopecia. Okay, scarring alopecia will be there. Then a mousy odor, sulfur yellow cup shaped crust will be there. Here also what happens is the central portion will be much clear, and in the periphery there will be some exclamatory sign like hairs and some hair bud like papules. Okay, that hair shaft will be lost, and hair shaft root will be remaining as some small papules. Then carrion is there. There will be some inflammatory, boggy swelling and marked loss of hair. That swelling will be painless. Then black dot is more in negroids. Black dots. That black dots represents that hair root portion. This can be compared. Considered under interleucta and the when you are getting one annular, ring-like lesion, there are so many conditions which is coming under DD. So we have to keep in mind, as we already mentioned, tenias are there. Then getae-like psoriasis. Okay, now that acute psoriasis is also, sometimes it also mimic as annular lesion. Okay, then granuloma, annular granuloma multiforme. Okay, like lesions also it will be annular, means so we have to consider that DD also. In leprosy, okay, in leprosy also there will be, but that thing is that it will be just like a plague like eruption. Okay, central portion also will be active. Okay, in erythema multiforme, porokeratosis, then DLE and SLE like lesions there also. In DLE there will be disc shape. Okay, disc shape means somewhat annular. Okay, then pityriasis rosea, pityriasis rosea, those happening, viral infection happening in children and all. Then sarcoidosis, then lichen planus, actinic lichen planus. Actinic lichen planus means those lichen planus which increase when sun exposure is there. Okay, then necrobiosis lipoidica, it's the complication of skin complication of diabetes mellitus. Then polymorphous light eruption. In polymorphous light eruptions also, most of the time there will be some annular lesions. Okay. And next dermatophytic lesion is Tinea Pedis. Here what we have to note that there will not be any annular lesion. Okay. There are three types of Tinea Pedis are mentioned. The interdigital, in this picture we can see this is the most common type, interdigital. Okay, in between the verse space there will be whitish and reddish, more or less white reddish lesions will be there. Then moccasin type. This picture in this slide shows moccasin type. So moccasin type means if the patient has called hyperhidrosis. Okay, hyperhidrosis, and the patient is wearing frequently shoes and all, and there is no fissures and all. Okay, and itching is there, and this kind of fine scales are there, then we should keep in mind chance of Tinea Pedis. Other DDs, most common DDs are there, Tinea psoriatic palmoplantar psoriasis, plantar psoriasis, and also footwear dermatitis are the most common DDs for moccasin type. Then bullous type Tinea Pedis is also there. It will happen rarely for those individuals having hypersensitivity to this fungus. This can be compared compared to alasam. Then onychomycosis. Okay, Tinea unguis. Okay, is the dermatophytic infection of the nails. So what here we have to consider in a dermatophytic infection of the nails are, there will be yellow discoloration of the nail. Then nail plate will be thickened. Okay. When we compare to candida, what happens is in candida the nail will be thick. Okay, there will be a history of water exposure. Okay, in housewives and those working in water and all, cloth washers and all, there will be chance of candida instead of tinea. Here what in those cases, in candida cases, there will be that nail plate will be thick, whereas here what happens is the nail plate will be thicker. Okay, then there will be subungual hyperkeratosis, and in beneath the nail plate there will be some dirty material accumulation. Okay, and tunneling also will be there. In this picture we can see that tunneling. Okay, and the incognito. Okay, incognito means no cognition, so it's very difficult to diagnose the condition. Here what happens is patient will already will apply, already has applied some topical steroids and all, and what happens is due to that application of topical steroid, that local immunity of the ointment, there will be complete remission of the disease, and the very next day there will be aggravation of the symptoms, and that also very severe aggravation. Okay, so in that case what happens is sometimes there will not be any lesion.
Okay, but the
next
complaint is very
upon
severe, and
so
most of the
when
time there will be lesions everywhere. In the central clearing, etc. features will not be there. Okay, so extensive asymptomatic or symptomatic recurring aggressive complaints will be there. Next means variety of superficial fungal infection is pityriasis versicolor. It's caused by Malassezia globus or furfur. Actually, previously it was called Tinea versicolor, but now it is known that it's caused by a yeast rather than a fungus. It's caused by yeast. So it is called pityriasis versicolor. So it will manifest like like two categories in. Fair individuals, usually sometimes it will be some hyperpigmented, whereas in a dark individual there it will be means hypopigmented. What happens is this yeast will be producing one acylic acid, okay, and that will inhibit the tyrosinase, which is present in the melanin production pathway. And as a result, there will be small poorly melanized cells will appear, and as a result there will be hyperpigment macules. Whereas those having hyperpigmented macules, where what happens is large melanosomes will be producing, and as a result the lesion will be blackish. Usually it will be asymptomatic, and this can be compared with our Shudra Sigma. Okay, Sigma is mentioned both as Mahakushta, and we are usually comparing Mahakushta Sigma with psoriasis. And at the same time, Sigma is mentioned by Samacharya as Shudra Kushta also. That can be considered as pityriasis versicolor. Okay, here in clinically we can very easily diagnose pityriasis versicolor by these clinical findings. Most of these hyperpigmented lesions or hyperpigmented lesion will be mostly perifollicular. Okay, and scratch test also we can perform if you are making a tangential force by using a scale or even by nail on the lesion. There will be fine scales, okay, as evident in the pictures. Okay, so hyperpigmented patch on cheek or face, these are the main DDs. Pityriasis versicolor, we already described the features. It will be perifollicular, then scaling become prominent on scratching. Then usually trunk more involved. Okay, involvement of face is also there, but in most of the cases, involvement of trunk is more compared to face. Okay, then pityriasis alba is there. Pityriasis alba, which is happening in atopic children. Okay, there what happens is there will be history of allergy. Atopy will be there. Then it will be recurrent in children. Fine scaling will be there. Okay, normal sweating and all, normal sensation will be there. Then indeterminate Hansen's. Indeterminate Hansen's will be that Hansen's, which will not progress to Hansen's disease. Okay, here lesion mostly will be single. Okay, multiple lesions are there. If multiple hyperpigmented patches are there, then first we have to consider the chance of pityriasis versicolor. Single or few, maybe we have to consider pityriasis alba. The single lesions, then normal sensations are normal sweating, no scaling, mild atrophy. Then from endemic areas, if the patient is coming from endemic area, then we should consider the chance of indeterminate Hansen's. When acute white patches, deep pigmented patches means it is vitiligo or leukoderma. Shutra we have to consider. Hyperpigmented, as we already mentioned, indeterminate Hansen's is there, pityriasis is there, pityriasis versicolor is there. Then Hansen's disease will be there. Then we have to check for anything is present is there. Then thickened nerve or nerve, presence of thickened nerve, we have to inspect behind ear and all. We have to inspect whether any thickened nerve is there, like that. Then post calasar dermal leishmaniasis chances is also there. These are not that much present in Kerala. Now coming to investigation. Okay, in the superficial dermatophytosis, the most important and easier method is potassium hydroxide smear. What we have to do is that we have to take some scrapings from the periphery, and we have to put it on a slide, and we have to add some 10% potassium hydroxide solution in that, and just heat it for breaking that fungal filament. Then mount it on a 10x microscope, then on watching we can see that fungal filament. Okay, on seeing that fungal filament, we can confirm whether it is fungal or not. Then other investigations are Woods lamp is there. Woods lamp, I mean, in Pityriasis versicolor and all is very helpful. Actually, it is present in market and in Amazon, like sites also is available. So in pigmentary disorders, it is very helpful. Okay, and those lesions which is present in intertriginous areas also, this is very helpful. And fungal culture. Okay, fungal culture also we can perform to identify what is the positive organism. Okay. Now we can consider the treatment principle. Okay, as we already found in our later discussion, in our previous discussion, that these superficial fungus clinical features varies as per the site. Actually, the causative organisms coming under the three categories only. So as per Ayurveda remain the same, but as per the difference in Adhisthana, the clinical features also varies. So in so we can consider almost same treatment in all, but as per the aggravation of dosha, we have to make some changes. Okay, so initially we have to administer some pitta or pitta kapha drugs, and later we have to shift to kapha or kaphavada drugs. Swedhagnam and Medhara drugs also we have to attribute because that contributes. Okay, Swedha and Medhas, we know Medhas is a cause of excess Swedha. So it will aggravate that disease. So that thing, aggravating factor also we have to make in control. Okay, so Swedhagnam, Medhara drugs also we have to administer. Then antifungal drugs, especially externally, is very important. Preventive drugs we have to consider. Those containing kapha, Gandhaka, etc. we have to consider. Then improving the immunity of the skin is very important. So we all know that Brajavita is the skin present in skin, and we all know that actually these spores, fungal spores, are present in air, but usually it affects those which are more their skin are more favorable to fungal growth. Okay, others will not get it. So that thing, considering that thing, we have to improve that Brajavita quality. For that, we have to consider some Agrotutejaka drugs also, because we all know that TOC actually is originates from Raktavaha Srodhas, and Raktavaha Srodhas Moolam are egg and play. Okay, so for improving this Brajavita or skin quality, we have to consider this connection, and we have to give some drugs also. Okay, and maintenance of good personal hygiene is also good. What happens is initially we have to consider some most of the time now we are getting in dermatophytic lesion, which is very aggressive, which are more spread, which affects more body areas and all. In that cases, we have to consider that diet and all also. Okay, and also we have to consider some Amabhajana drugs, etc. initially, along with the Scrimigna drugs. So the kashayas we can use are Padalumuladi, Padalagadranadi, both are Pitta Kabhara, and Samsana quality is also there. Then if you need some Swadagna and Agnivarda drug, Guluchya, kashaya is a good choice. And then Swadagna, Pitta Kabhara we required, Pranamadi we can advise. Then in chronic cases, Aragudadi is good. In very severe spreading lesions, Nirkundyadi and Kudajadi kashayams are OKD we are seeing is much beneficial. Actually, Nirkundyadi and Kudajadi kashaya are mentioned in the case of Drimi Prakarana in Sahasra Yoga textbook. And the guligas we can administer here include Viluadi, Kremigna Guliga, Gandhagar, Gandhagarasana. Actually, Gandhagarasana are very much essential for controlling, since we all know that Gandhaga is a most Kremigna drug. Then in much spreaded severe conditions, we have to consider the use of Manikudra, Gula, Charya, Smear, etc. Now the Arista or ASO combination is useful. Here Aragada Arista Puranavaso combination we can administer Lautrasama as Prati, especially if there is a Mendovruti, we can consider that usage also. Hydra Gandam Rajanya Churnam, actually Rajanya Churnam in children is much beneficial, and patients having lifestyle disorders like diabetes mellitus also is very beneficial. It's very beneficial for controlling that contour and also for normalizing the skin health. Now, external medication, we have to do some combinations or single drugs having cremigna drugs. Okay, Nimbahridhyadi Churnam is mentioned in Ashtangaridhyam Chigilsasana Pushta Pragarana, Nimbahridhyam Surasupatolam, Pushtasho Kende Surida Sigra, that yoga. Actually, it's very much beneficial in chronic cases. It's mentioned Thai Takra Pishtai. Actually, that drug should be applied after mixing with takra. So in severe cases and all, we can advise Nimbahridaya Churnam with takra application and followed by some oil application. Okay, Krivigna oil application. Then Nimbapatradi Churnam is mentioned. Nimbapatradi Churnam contain Nimbapatra, Gandaga and Neem. That 3 drugs only. So since it contains Gandaga in acute stages, it will be better compared to Nimbahridradi. Then Ayurveda Patra is there, it's the single drug, but the importance of Ayurveda Patra is there. The Ayurveda Patra, Ayurveda root bar, all contain, all are very good dermatophyte killing action, antifungal drugs. Okay, it contains, especially it is very beneficial for all these 3 kinds of dermatophytic infections. So we can administer Ayurveda Patra. It's very beneficial in my practice also. Administering Ayurveda Patra very beneficially. What happens is we should keep in mind that there is chance of burning is there. Okay, so we that thing we have to tell the patient is that there is chance of some burning, and in some cases what happens is there are some burning was severe. Okay, and some contadermatitis already formed in some cases. Okay, some bullae like lesions already formed. So what happens is usually we can advise them along with curd, they can apply so that tishnata will be reduced, and it will make more fat soluble substance will get absorbed through the skin also. So we can advise along with the curd, we can advise them to apply Ayurveda Patra. Before application, they have to check skin sensitivity also. Okay, by applying this mixture in some normal skin area. Then if any secondary infection is there, you can advise so labana should be done in acidic medium, and duration should be more if possible. If possible for the patient, it is better to administer whole night. Okay, in fungal eczemas, if any secondary infection is there, then don't go for any labana initially. Then thylas are mentioned, which beneficial for fungal include Kimchik Patradi Kairam, Aditya Kairam. Actually, these mentioned in the case of Pama Pragarana in Sastra Yoga and all. These yogas are very beneficial in cases where widespread lesions are there. So in that case is also very beneficial in these style yogas. Then Mahatitagam like Lebam, Rasotama Lebam, especially in all Teneas is beneficial. Then some prayoga like Argadapatra, Takra, Kalkam, I already mentioned. Then Marijapatra, Pada Patra. That labor is also good, especially in the case of Tinea Unguis, and all it is very beneficial. Then Tribala Kashayam Tuttam Dhara. Okay, if any furrows are there in Tinea Unguis, for cleaning that furrows, we can advise Tribala Kashaya plus Tutta Dhara. Then Arigapatra Tagara plus Tutta labor is also very beneficial in Tinea Unguis. Nowadays we are getting, here we are getting so many cases which are very widespread. in all family members affected like that lesions we are getting. And this thing also we have to keep in mind in later stages after that uh, after curing that itching and all, for getting rid that post-inflammatory hyperpigmentation and all, or we have to administer some Varniogas. Okay, at this stage there is no need of giving drugs, antifungal drugs. At that stage, we have to consider the use of Eladicera, water, glutathic acid, churna application, alpha-amrati, like Varniogas. Okay. Next case, we can consider PIEDRA. PIEDRA also we are getting not that much frequently. It's a hair shaft fungal infection. Two kind are there: white PIEDRA and black PIEDRA. White PIEDRA there will be white spores, whereas in black PIEDRA there will be black spore. So what happens is it is due to that wetness of the hair. Okay, so we have to advise the patient to make hair dry all the time. That will be sufficient. If then also it is persisting, we can advise them to do some dhubana with Google Bandivale Journa or Dimbavatra Journa, etc. Now considering the next N18 infections, that is bacterial infections. First of all, Pedaga and Vidadi. Pedaga means furuncles can be compared to furuncles, but carbuncles means carbuncles are more deep-seated. There will be multiple openings. Okay, the furuncles, there will be one inflammatory nodule. Okay, actually what happens is most of the time some folliculitis will emerge into a furuncle, and furuncle, if clear treatment not obtained, then chance of getting into carbuncle stage is there. Okay. So in this stage, what happens? I mean, some externally we have to give some alpamara or turmeric decoction chalna is good, kartova test application is good, and we have to consider kashayam like Guggulidithakam, Nimbambadadi Panchadiktakam, Sonidambadam like kashayam. Then Resasinduram, Pravala Basmu combinations, like then Cheriya Madhusni in vacant cases, like those which is beneficial for Krimihara and Pagahara. Okay, drugs we have to administer. Then impetigo or ecthyma, okay, it's very common in our OPDs during summer times. It can be considered under VISARPA, VISARPA. So here there will be superficial blisters filled with the purulent material. Okay, honey-colored gummy crust will be the purulent material will be there, and there will be some erosion. Erosion, as we already discussed, there will be loss of superficial epidermis. Okay, so these features, by seeing these features itself, we can clearly clinically diagnose impetigo. Okay, ecthyma, deeper form of impetigo is called ecthyma. Okay, if at all we required any lab investigation, we can go for post-gram stain and bacterial culture. Is of two kinds. As in the in previous slide also we saw non-bullous impetigo. So two kinds of impetigo are there: non-bullous and bullous. Okay, in non-bullous is more dangerous. Okay, it's also called impetigo contagiosa. Okay, it is usually happening due to staphylococcus or streptococcus or combined infections. Okay, and we should keep in mind there is every chance of post-streptococcal glomerulonephritis in non-bullous impetigo. Okay, in my clinical practice itself, I have seen one case. Okay, in that case, what happens is, patient already took some not Ayurveda, some traditional treatment and all, and what happens is, the child kidney damaged. Okay, here unfortunately that non-bullous impetigo happened to that child due to nephritogenetic M49 strain of streptococcus. Okay, if that strain get infected, okay, if that strain happens to any child, there is every chance of getting
glomerulonephritis. So okay, so we can't take I mean chance in these cases. So I mean we can't know, I mean that it is due to M49 strain or not, that we can't know. So in that cases, if at all in a particular case happening to come to visit our OPD, what we have to do is regular follow-up is mandatory, and more we have to advise to monitor urine output regularly and temperature. Okay, we have to monitor temperature, and we have to watch for any presence of facial edema. That also we have to instruct the parents. Then Bullous Impetigo is there. Bullous Impetigo, usually small children will be getting this kind of infection. So here vesicles will be there. Okay, pus filled vesicles and bullae will be there. So the confirmatory feature is there. There will be hypopyon sign. Okay, clinically, if you are seeing this hypopyon sign, clinically we can diagnose bullous impetigo. What is hypopyon sign is in that loose bullae, there will be in the bottom there will be pus. Okay, this is called hypopyon sign. Okay. So there will be greasy crust and all. I mean, if the patient is coming after a few days, and if at all that vesicle is not there, we can see that a rupture. Okay, rupture will be there. The greasy, I mean, crust will be there. From all these things, we can identify that case. Actually, this one can be compared to Pola Karapan mentioned in our Arogya Kalpadruma, which is the most I mean, famous traditional I mean, textbook, pediatric textbook from Kerala. So this can be considered under Bala and some beneficial yogas include Chandranadi, Chandranadi or Chandravarpadagadi yoga is mentioned in Sastra Yoga. It's available in market for SNA pharmacy and all is available. Then Tiktagam Kashayam is good. Shonidamrudam. Shonidamrudam contain Padya, Gobagana, and Nimba, 3 drugs only. I mean, for potentiating this, I mean, the bacterial action, for potentiating the bacterial action of the drug, we can add some prasheba of that Nigella sativus carinjiraga, then HT, and that what is called Madhusni, Shodhita Madhusni. Okay, these things also we can add as prasheba churna in Shonada Amrita. That will give a much quicker effect. Then Mulagati Kashaya is there, Shani Badya, so Nimbamada, so then Chandraprabha. Then to control that temperature and all, Surya Prabha, Gobi, the drugs will be beneficial. Then some Rasasindura or Siddhamagrita drugs, Rasasindura along with the Pravala Basma administration, we can, it's very safe also. We have to consider that to control that infection. And Arogyavardhini Vadi is also a beneficial drug. In initial stage, since the pitta aggravation is much more, don't go for any levaga or abhyanga. We can consider Ashalna, Ravagaha, Sega, Thara, etc. Padalamuladi, Nalpamradi, Lodasevia, the Kashaya, Tribala Kashaya with the Tangana disorder. Tribala Kashaya with Tangana disorder is the, I mean, short in, especially in Bullous Impetigo. Okay, non-Bullous Impetigo, I mean, there is, I mean, some risk are there. So we should consider that also when we are treating. So Bullous Impetigo we can mean comparatively is easier to manage. Yodrasivya Kashaya is mentioned in Luda Pragarna in Ashtanga Uttarasthana. Rasasinduram can mean safely we can administer in this dosage. Mean 1 by 6, 25 gram, like that. We can mix it with 10 milligram of Pravala Basma, and in honey or lemon extract we can give. Okay, to make it more palatable. Then actually what we are seeing in that in Impetigo and all in both in Bullous and non-Bullous, if you are applying some advising some external antibiotic cream, it itself usually will cure the disease. So that thing also we will keep in mind. So our antibiotic cream usage also we can consider. Next case is cellulitis that can be compared as a VISARPA or KOH. In the uncomplicated stages, okay, in we all know that if it is severe, we have to give some Systemic antibiotics and all we have to give in uncomplicated stages. In acute stage, we can consider if using is more Vajra Kashayam, we can consider. If the lesion is fever predominant, Amrodhra and Laya Kashayam will be beneficial. And if the erythema and pain, if more, then Mahabharat Manjishtadi like combination will be better. Then Punanasam, Bamradasam, Vetumaran, Surya Prabha Sudarsanam, like combinations. Then okay, what happens is in the initial stage itself we can consider the use of what happens is in the pitta vruddhi stage actually thaila is contraindicated, but has got no qualities of thaila. We can very well administer in a pitta vruddha condition. There will not be any complication. So for Avagaha, we can consider Padola Muladi, Nalpambradi, Tripaladi, and Sikirunavadi Churna. Sikirunavadi Churna actually is coming consider mentioned in Prayogasamcham Kriya Kamudi like Visha test. Actually, is mentioned in the context of Mandali Vishajisopa. So it contains Tishna drugs. Okay, Sikru Tishna drug contained, but actually the pragarana by its prabhava is pitta. Okay, so it can be very well. It has got more shrodha penetrating action, so it can be very well administered in the case of cellulitis and all. In the stage 2. Subsided. In stage 2, we can consider the condition as Uttana Vadarakta condition, and in that stage, we can consider the use of Kogila Shampunata, Nadi, Rastandadi, like combination. Hello, is it okay? Is it audible? Everything is okay?
Yes, sir. Audible it is.
After corpon lady dilena poya pare.
Yes.
Okay. Next one is folliculitis. Okay, folliculitis mean from this picture itself we can very well diagnose the condition. Here what happens is that there will be beneath the around in the beneath the hair, that follicle there will be pustules and papules. Okay, and there will be some red halo around the lesion. Okay, if not treated at the correct time, there is chance of chance of getting this lesion into furuncle or carbuncle stage. Okay, so folliculitis may arise even syphilitic. Okay, so it can be compared as VISPHOTA. Okay, and here we have to administer Kavapita Samana and Crimigna drugs. Okay, Nimbadi, actually Nimbadi Kashaya is mentioned for Pidaga itself. It's a very good result yielding combination for folliculitis. Then Shonadamrita Kashayam, as I mentioned before slide, that if you are administering that Prashava Drivya also, it is a good choice. Then Trandyadi Kashaya is also mentioned in Ashtangarde Chilsa Sanam Vidridi Pragana. That also a good combination if so much pustules are there. Then Vilyadi Krimignum Kaisharu. Dushishayati is especially beneficial in chronic cases. Okay, in some cases, patients what happens is the folliculitis will be chronic and recurrent manifestation will be there. In that cases, we can consider the use of Dushishayati also. Sharibadhyasya combination is good. Externally, dhara, if itching is there, we can consider mixing it with salt. Okay. Ayurvedic is good. Sadavadagruda Parandhyadikara is good. Parandhyadikara, actually, that also is mentioned in Kriya Kaumudi and all, the case of Mandali Vrana. So it has got one good pitta curing capacity. Okay. In chronic or deep cases, Ayurvedic Kashaya, Mulagati Kashaya, Ayurveda Mulagadirishta, and Prachana is very good. Okay. In my OPD also, I got 2 chronic cases. Very severe with severe itching and all, not responding to internal medicines and other conventional system treatment also. That case.
on doing prachana, I was able to give instant relief at least for 6 months. Okay, that patient was there for up to 1 year. In one patient, I got almost complete cure. The other, after a few months, I lost that follow-up. Next one is trichomycosis axillaris. This case also I got in a few patients. Here what happens is there will be some dirty material in the axillary hair. Okay, and the patient will complain that after cleaning with soap and all, that dirty material is very sticky. It is not going. It's a misnomer. Trichomycosis axillaris. By this name, we may misjudge that it's due to some cornea bacterium species. Okay, so here what we have to do is that advise the patient to shave the axillary hair and to do Crimigna lepana. Then another case we will be getting in our OPD in rainy season. Okay, and those having hyperhidrosis is pitted keratolysis. Pitted keratolysis. It is due to corneum bacterium or micrococcus sedentorius. What happens is in that patient's soul there will be pits. Okay, multiple punctured out cribriform pit. Okay, it's actually formed due to digestion of keratin by bacterial enzyme. Okay, usually soul will be more affected. Okay, and the patient will be complaining hyperhidrosis also. This we can clearly see that it's. So here also what we have to do that we have to give some medicines. Okay, so like the key and for reducing that hyperhidrosis. Most of the time curing hyperhidrosis is very difficult, and some antiperspirant tangadam powder tangadam like some antiperspirant powder we have to advise. Okay, or nimbapatra churna like that we have to advise. Then some tikka like that combination that will be giving result. Then erythrasma is also very common. As we discussed in the case of pityriasis versicolor, like the fungal case, pityriasis was there, along with or separately also erythrasma will be getting in our OPD. So asymptomatic, scaly, irregular, pink, brown lesion over intertriginous areas. Okay. Here also treatment we have to opt. What we have to instruct them that it will take time. Okay, it will take time for complete resolution. For resolving the lesion, it will take time. So this medicine they have to continuously apply. In this case, both the pityriasis versicolor and erythrasma combinedly happen. In this case, we can consider viral infections. So viral infections, those appear in our general practice include purely cutaneous, localized lesions, and some exanthematous systemic infection coming along with the fever. Okay, so purely cutaneous include warts, molluscum contagiosa that can be compared under, considered under Cathara, Majagili, etc. Exanthematous we all know. It's Vada Pitta predominant. It can be considered under VISARPA, Masuriga, Luda, etc. Because some one reference is there. Anyavadati, Buddhasya, Dustasya, Anyasya, Mochana, Sampavanti, Vishaspuda, Eluda. In the context of Eluda in Ashtanga Sakra, it is mentioned that due to some internal causes, okay, due to some vitiated ahara and all, there will be some vesicles or bullae appearing in body, that also can be considered as luda. So not spider bite only can be considered under luda. This kind of vesicular or bullous lesions appearing as a result of internal pathology also may be considered. So these exanthematous systemic infection include varicella, measles, herpes, etc. Coming to warts, we all know benign viral warts actually it affects everyone, and it is due to human papilloma virus of more than 135 types, and it can be broadly classified into genital and non-genital. Okay. So coming to warts, warts actually arise. You all know actually arise on the face, in the dorsal aspect of fingers and all. In foot, it will be there. Okay, it can be compared as Kadara or Sarmagila. So one confirmatory sign that we have to keep in mind is that actually by seeing that follicular, that filiform parts itself, that cauliflower like appearing parts, we can, from seeing itself we can identify. Okay, but the identifying feature, one identifying feature is that on removing the top layer, top layer by a scalpel, or when we are doing acne and all, on removing the top layer itself, there will be thrombosed black vessels. Okay, as we'll be seeing as black dot. Okay, it's a confirmatory sign in warts. So there are, three types are mentioned. Common warts is called verruca vulgaris. Then plantar warts are there. Then verruca plana or plain wart. Okay. So here it is the plain wart. Okay. In seeing on the eyelid below eyebrow. Okay. It they mean on the beard also. It's a flat wart. Okay. This here what happens is this that eyelid, it happened due to maybe due to some cosmetic reason. Okay, but what happened, that patient ignored that, maybe she removed that eyelashes and all. Due to that injury and all, it's spread. Here due to shaving, it may got spread. Yeah, and beneficial treatment modality, acne karma itself. Okay, if patient is not willing, we can consider shara karma. Then Gugulitham Kritam Sasyagam combination is also good. Then some Siddha medicines also mean available. Markets are very beneficial, like Kalana Columba. Then Indra Thailam is available for Imis pharmacy. It's also good. Sotamadi Levo, Hatha Levo, etc. In what those affecting in soul and almost beneficial treatment is Agni Karma using Agni Salaga or poultry. Now coming to next entity, that is molluscum contagiosum aegaliga. Here is common in infant and children. Hello. Hello.
Sir, hello, sir.
Dr. K.
Sir.
Is it audible?
Yes, sir. Yes, yes.
Oh, okay. Here what is the diagnostic criteria is that the papule will be skin colored and umbilicated. Okay, umbilicated. Umbilication means there will be some central punctum, central depression. Okay, in our test also it is mentioned as Mudga Sanipa. So like one depression is present in Mudga, here also one depression will be there. So with that feature itself, we can diagnose clinically this condition. So here Vilyadi Guliga, Criminodi, like internal medicines, then HT Labana and Vilyadi Guliga Labana in those which are not severe, these will definitely give yield. In severe condition, we have to go for some immunomodulated drugs also, and Bedana. Bedana is a good treatment of choice. Okay, for that we can use that insulin needle. Insulin needle, if you are using, is not that much painful. Okay, what we have to do is that one virulent material is there. So one virulent whitish crystal material. That thing we have to remove from this papule. Then herpes, next one is herpes. That herpes simplex is very common viral infections of two kinds, genital and oral. Of these, oral will be getting, in numerous cases. Okay, the patient will be complaining that after taking some masala food and all, some eruptions happened and mild fever was there, or without fever also, patient will be coming to our OPD. Okay, this like clustered, grouped vesicles. Okay, and with some erosions, that clustered will combine to form large, like that with or without fever. Okay, in those having herpes simplex that coming for the first time, there will be fever, and those where recurring herpes simplex are there, the chance of fever is very less. So this clustered vesicles in the nasolabial area, we can confirm that it's herpes simplex. Okay, then herpes zoster is there. It's a painful blistering rash. Okay, you all know it's due to reactivation of chickenpox virus. So usually in adult and elderly, in immunocompromised happen. So what happens is most common affecting areas are face, trigeminal nerves, then in axillary area, then in thigh. Okay, so here also we have to keep in mind those herpes affecting in the ophthalmicus division of trigeminal nerve is also very dangerous one. If a patient coming to there with vesicles, grouped vesicles on one side of forehead and all, if any vesicles are there on tip of nose, you should keep keep in mind that its nasociliary branch is infected, and there is every chance of keratitis. Okay, so that is better to refer. Okay, better to start as I flow here, because it's not good to take a chance so that the patient loses his vision. Okay. Here we can consider Aluda Chigilsa, Agnisarpahara Chigilsa, Masuri Spota Chigilsa, Vada Paitera, Shida Vidya Criminal Chigilsa. External and internal administration. Then Nili Daladi Kashayam, then Padora Gadrona, or Chandana Varpagadi like Kashayam, Trayandia Kashayam, Viluadi Sandra Prabhakar Vigna, Saribadya Son, Punanavason, Alpamra, Alpamra plus Safety Dhara, Tripala Dhara, all these are beneficial. And what we have seen that if you are at all giving any external administration, most of the time there is chance of aggravation. So for that, for avoiding that aggravation in external application, these Cottam Ramachari is a good external application which will not give any aggravation. It contains Cottam Ramachum, Chandana, and Nilindra, 4 drugs only. It's a very beneficial drug in herpes. Zoster. Then Shadavada Grudam, that also with the Dimbapatra Swarasa, if you are giving, chance of aggravation is very less. If in associated neuralgia, we can consider use of Brahmidrashadikashayam, Nidaladikashayam. Then Tikta Grudam in Shamana dose. Then Pindadaila or Shirabala 101. Pindadaila and Shirabala 101 extra application. Then HFM, hand, foot, mouth, this is also in our OPD usually in children will be getting. Here we have to check for that red papules in sole, palm, then hard palate. Okay, in some severe cases, this lesion will be there on forearm and leg also. Here it says mostly it's a self-limiting condition. So if this much of severe it is there, we can go for some Jarahara, Blujiadi like Brudotra like conditions. Yoga. Then Punanavasa is there, tablets like Gobizina, Dividuadi, Suryaprabha. Then Shalanam, Ravadaha with the Tripala, then the external application. Now the next infection condition is parasitic. Parasitic, in that also most important one is scabies. You all know that it is caused by the itch mite, Sarcoptis scabi, Varhominis. So here the feature will be severe nocturnal pruritus, and the close relatives will also have the same complaints. Then presence of burrow. Here, burrows, papules, papulovesicles will be their primary lesion, and those living in unhygienic condition, there will be secondary lesions like pustules, eczema, secondary eczema, the nodular lesion. Okay, In children, I mean, we should this child came to my OPD. We have to usually what happens is in adults this might will not affect face, palm, and so. Okay, these will not affect. Then that might will be affecting in the intertracheous area, then pubic area, then cubital fossa, like that. But if at all you are seeing any vesicle-like lesions on palm and sole of a infant, okay, child year less than or up to 1.5 years, and some lesions are there on face also, then the first lesion, first disease we have to suspect is scabies itself. It's an infected scabies. Then nodular scabies is there. It's a hypersensitivity response to mite. Some persons will be very much hypersensitive to this itch mite. It will cause some nodular eruptions on scrotal area. There will be nodules on genital. On examination itself, we can see this nodule with severe pruritus. So the diagnostic test here we have to employ our potassium hydroxide or amount of stampings, demonstrate mites, X fecal pallets. Then fountain pen ink application in burrow is also mentioned in test. Then wood slam we can do in OPD if wood slam is the if a fluorescent substance is applied on burrows, it will fluoresce. Can be considered under PAMA. So in that, I mean, we ensure we can, if we are giving some contained drugs, we can we will get the sure result. Criminal drugs containing Ajipaga, etc. will be very beneficial. It is very severe. We can go for Padalagadroni, the and Haridraga combinations. But I mean these cases also I mean came to in my OPD because there were some bed bugs in I mean my IPD in my government hospital. So here what I mean actually bed bug now it is not that much prevalent. So what happens is if at all patient goes to any dermatologist and I mean if at all visiting any dermatologist, they will diagnose it as some contact dermatitis material. They will diagnose because it will appear like that. But on clear history taking only we will diagnose the case. So bed bug, what happens is I got few cases in that I mean I previously already seen some cases. So with some interrogation with that history itself only I mean came to that diagnosis that it's due to bed bug. So it actually in bed bug cases and all importance of history is I mean a key factor. Okay. Then these cases are also I mean will be appearing in our OPD like pediculosis. Okay, pediculosis capitis is very common in children. Okay, head louse. Okay, with intense itching often have positive. But we have to keep in mind that in severe cases, those having immunity is less. Those severe cases of children, there is chance of posterior cervical lymphadenopathy. Okay, if the patient is coming, I mean parents are coming with their child having posterior cervical lymphadenopathy, we should keep in mind that there is chance of there is chance of head louse. So by giving head louse treatment only it will get relief. Okay, and by seeing that cases itself we can come to a diagnosis. Then pediculosis corporis is the those neglected people usually be getting this pediculosis corporis. Then pediculosis pubis in young individual usually we are getting, but is the here styrus pubis is the causative organism, and it is like a crab like organism, and this is not that much familiar among people. So they will fear, and they actually I got few cases and they were not at all familiar with this organism. So they feared, and actually it is very difficult to remove. It is very stick on a body also in pubic area and chest area, axillary area, in chest area. This one will be more prominent. So here what we have to do is that shaving that pubic or chest hair is very important, and application of Gandhala, Thaila, Antibhaga, like filming Thaila is also will give result. And in severe cases, we have to keep in mind there will be some blue slate colored macules on body. Okay. Here Nimbapatra, Tulasapatra, Levana, Eladi Gana Churna plus Kanji, then Eladi Churnam, Durpatra, all these will be beneficial. And in rainy season, we will be getting some insect bite hypersensitivity or papillary cases also in children. Here also what happens that it will be some central punctum bearing papules. If you are provided the central punctum bearing papules will be there in exposed area. Okay, legs and hands. Okay, in some severe cases, whole body will be getting affected. So you have to keep in mind the morphology central punctum. We have to keep in mind. Okay, and most of the time, there will not be that much mosquitoes also. Okay. So, those where lesions are more in extensive, exposed areas, and patient, the child has a history of atopy, and if it is, complaint is more in rainy season, then they should, come to the papillary area diagnosis. So here that central punctum is much visible. Okay. Here the Bamada Panjata, Madalenia, the Shankam Holika, Churnam, STD function, Inchu, Sadha law complication, all these will be beneficial. So by this we finished our infectious cases. Now we can go to eczemas. As we already mentioned in our initial slide, there are endogenous and exogenous eczemas, and eczema also, as per morphology, can be classified into discoid, lichenified, seborrheic, and hyperkeratotic. Then, as per is acuteness, acute and chronic lesion like that also we can. So in eczema, actually usually we are comparing it with Vijarchika, but when we consider the histology and clinical examination, on acute stage there will be much spongiosis, that is intracellular edema or accumulation fluid will be there. Okay, as a result there will be exudative fluid will be discharged. Okay, in chronic case what happens is along with this spongiosis will be less, along with that hyperkeratosis and acanthosis will be there. Okay, on histology, so the lesion will be lichenified. Okay, so there will not be any exudation, but we should keep in mind that there is every chance of aggravation of pitta, so we should not give any Tishnal Abana. Okay, Tishnal Abana, as when we will be discussing Dichoplanus, there is no harm in doing any Tishnal Abana. But in these cases, since spongiosis, there will be all the time there will be some sort of spongiosis. So Vijarchika, we can compare it as lesions having spongiosis at any stage of the disease. So among the eczemas, the most common one is atopic dermatitis that appearing in children. So this one is in a child bearing age more than 1.5. Actually, in infancy, the lesion nature will be different. So okay, in these children, what happens is there will be facial involvement, then flexors will be involved. Okay, and in chronic cases there will be erythema and puffiness. Okay, edema will be there, and there will be flexural cracks. Okay, then fine scales will be there. Okay, so here along with that disease feature, there will be some family allergic manifestation history, atopic history there, and tendency to recur. Okay, actually in those having atopic dermatitis, actually what happens is some genetic problems are already there. That philangerin gene is there, that is the gene responsible for moisture maintenance, that will be mutated. Okay, in infants, their lesion will be somewhat different. Their extensor aspect will be involved. Flexors will not be. Okay, so infant. Okay, here we can see extensor aspect and the facial involvement is much more. In that child, we got complete relief. Okay, here diagnosis is by UK Working Party diagnostic criteria is there. Then Hanifi's statistical criteria is there, that not required. In UK Working Party diagnostic criteria, itchy skin plus three of the main features like visible flexural involvement, then dermatitis, dry skin, atopy history. Then in those children of age more than 4, onset of a signs and symptom under 2 years of age. And we should keep in mind that there is a viral complication is also there. Okay, in these children, if this kind of honey-colored exudative, painful hemorrhagic rusted areas are happening, it's called caposis varicella eruption, eczema herpetica. Okay, that complication chance is also there. That also we should keep in mind. So, okay, in acute stage, in Pittagabara chilsa we have to do. Mulagadi Dilgudyadi like will give good result. Sharibhadyasa, Vishayasam combination is good. Aragada Punarnavaso combination is good. Gobichandranadi Buliga we have to administer. In severe cases, Gobichandranadi in tender coconut water, if you are giving, it will give a better result. Okay. Then Rajinadi Jurna Chandraprabha combination, Hydragata Pilyadi Shana. In later stages, Vadaga Bahara Chilsa without shading. Okay. Here, what happens is the dryness all the time we have to avoid. Okay. Aragadi Kashaya, Hydragandam, Aragadi Grida, Aragadamasa Grida, Mahatika, Kalyanam, all as per condition we can administer. Okay. And externally, Nirgundyadi Kashayam drug we can make a kwada and we can give for Shalana Udaha. Better to go for sponging. Okay, sponging, in that sponging also add some lubricant like thicker ghee, like that we have to add. Then give some sponging. It will give much more result. Okay. Reguladi Kashaya Sushma Churnanabamradadi, Padoli Muladi Kashaya Sushma Eladi. Okay. Then some external single drug formulations are mentioned, Shariva Mula in and also this Paradi flower paste in coconut milk. Actually, what happens is in some patients beneficial. In most of the children, what happens, they will complain of burning after application, so they will discontinue that. So that means result I have not received by this combination. I usually give thicker ghee or Panchavalkadi Yamakam also is good. Panchavalkadi Yamakam. Then for Aushadi one Carapan is good. So in some patients that also is good. Okay. Then Manjishtadi is there. Panchavalkadi Ayaladi Samprapthi. So avoiding Dukshada is very important. Continuous application on Alpamradi even if however whenever lesion is dry, you have to advise the parents to give an application. Then if there is asthma, eczema syndrome is there. Both alternately is coming, then Elaganati Kashayam is a good choice. Now stasis eczema. So in stasis eczema, what happens is there will be venous return compromised. Okay, due to prolonged standing, varicose vein, etc. Okay, so stasis eczema means due to lymph flow blockage. Also, same complaint will be there. Side lower third of leg, cover medial malleolus, brownish pigmentation, edema, exudative, crusted lesion on lignite lesion with varicose vein or evidence of venous stasis. Okay. So what happens is, as a complication of that, the stasis eczema will be there. It may lead to varicose ulcer like that condition. Also, it may lead. So in the inflammation stage, we have to go for Pitta Siragrandi treatment. So in that, Panchadam Kashayam, Nimbadi, Gokulashan Kashayam, Piranavadi, and then Sahadrati Kashayam plus Avadi, because it is mentioned in Ashtangati Chilsastana for Navotha. Siragrandi, that also is good. Then Tripula Nalpamradi Dhara with milk, if severe pain. If severe pain is the if ulcer like that is there, it's a very good one. Tripula or Nalpamara Kshira or Desimula Kshira Dhara is it will give a instant relief. Okay. Then skin changes if there is there, then Uttana Vadrata treatment we have to adopt. Then Mridat or Manjishadi Kashayam. Then Titan Kashayam Pinta the elevation application will be beneficial. If the venous ulcer is there, then we should give Google the Babadaso, Viruvanjulam, Sharaskara, Dhara, Avgavata Bhala, Nalpamara, or the Simula Dhara, then Parindia the cream. Padyajalam made and the cream is good. In all these, I mean, also cases, Gugulu Panchapalam, giving Gugulu Panchapalam is good. We can use it for Dhupana also. Okay. Since maybe by our medicines, that lesion will be subsided, but that problem of a venous return problem still there will be there. So, in order to cope up with that, we have to advise some varicose vein stoppings also along with this treatment. Contact dermatitis is also will be appearing in our PD very frequently. This one very common one is foodware dermatitis. Okay. Actually, so many there are things are there. Okay, Parthenium usually very here in our hilly area, Wayanad and all its cases are very familiar, very common. So and other sources of contact dermatitis are nickel in jewelry, then fragrance, formaldehyde, parabens in cosmetics, then mercapto in rubber and rubber gloves and all these things will cause contact dermatitis those who are susceptible. Okay, so it is of two kind, irritant contact dermatitis and allergic contact dermatitis. So cumulative irritant contact dermatitis also will be there. Very commonly will appear in OPD. Common example is houseflies eczema. In allergic contact dermatitis, there will be some sensitization phase initially, followed by some clinical phase. And here, immunological type 4 hypersensitivity is the hypersensitivity involved. Okay, and the confirmation here is by patch test. And special forms of allergic contact dermatitis is there. This picture is a photodermatitis case, and also phytophotodermatitis is also there. Okay, this one is phytophotodermatitis, not photodermatitis. The difference between phytophotodermatitis and photodermatitis is that in phytophotodermatitis there will be Parthenium allergy and photodermatitis. So what happens is clinically in phytophotodermatitis there will be involvement of below the eyebrow there will be lesion and below mandible there will be lesion. Okay, whereas in photodermatitis, since these area there will not be direct sunlight happening, there will not be any lesion. Okay. So here Nidana Parivakana is of prime importance. All CDs could be compared to Garaja Vigaras. So Pitta Kapara in acute stage, Vata Kapara in chronic stage. Incorporating Garahara drugs give more promising results. Okay. This application should not contain irritating drugs is also very important. So as per the acuteness, and if any secondary lesion is there, we have to consider use of like drugs also. And then for Shalna Eastern application, Guluji Satum, we can consider Triphala, Tangala like that. Also, we can consider. Then Avagaha is preferred. If that much exudates are there, Avagaha is preferred compared to Lebana. Okay. Then Chandranadi one Churna is there. I made this for few patients. It was actually just mentioned in Samhita Kalpasthana for Padavasha. It's a very good choice. Next one is seborrheic dermatitis. Okay, seborrheic dermatitis is also very common in our OPD. Most of the time, some old age fellows will be coming seborrheic dermatitis after hair dye application and all. So erythema and disease scales are the features. Dandruff, mild dandruff actually is mild seborrheic dermatitis. So okay. So along with that, if nasolabial involvement, eyebrow involvement, axilla, then flexor involvement is there, we will mention crust, etc. is there, we will describe that as seborrheic dermatitis. So scalp, eyebrows, eyelashes, then nasolabial fold, retroauricular region, pre-sternal and interscapular regions and flexors. All these should be Kapapithahara drugs should be employed, and the gandham containing Primera drugs is also good because most of the modern textbooks are mentioning that there is presence of Malassezia yeast in seborrheic patients. Okay, so that thing also we can consider. Next one is discoid eczema, that is otherwise called nummular eczema. So the patient will be showing eczema which are oval, okay, or oval or dish shape in morphology. Okay, is one is nummular eczema. This one is a nummular eczema keyword. Then asterotic eczema will be there, or cirrhotic eczema. This one is more common in adult patients. In those patients having dryness of skin also, this kind of cirrhotic or asterotic eczema will be there. Here restoring skin hydration is very beneficial. So Tiktagam Narasimharasanam or Tiktagam Chavanaprasam combination, that thing will give you good result along with along with Pittagabhara, Vijarchagara drugs. Okay, we can see that dryness. Okay, then fibrous dermatitis is also uncommon in our area where so many trees are there, hilly areas and all during rainy season. What happens is here this beetle, okay, this acid fly dermatitis, it is also called acid fly dermatitis. This acid fly, what happens is will stick on our body during sleeping and all. What happens is it get crusted in our flexor area, and that coelomic fluid will escape from its internal body, and it is a very irritant one. On touching that coelomic fluid, it will cause some irritant dermatitis. Okay, so if the patient is complaining some kind of kissing lesion. Kissing lesion means if the hand here lesion is there, on touching here on upper arm also there will be lesion, and similarly on neck, if lesions is there, on touching here also same lesion, like that. Acute onset lesion on waking up from bed, like that, if patient complaining, then we can definitely confirm that diagnosis as Pedras dermatitis. Here we have to do some PIJU, like external sponging and all. External lavina is contraindicated. External lavina even with Vilyadi Guliga is not good, because Vilyadi Guliga is contains some seasonal drugs. And here it is a very pitta predominant condition. So in that stage, if you are giving Vilyadi, means it will aggravate that condition. Here we have to give some soothing and Pittahara action application. So Lothra Seviadi Kashaya Piju, Nalpamara HTPJ. Then Kumari pulp, okay, aloe vera pulp application is good. Ulijadi Kashaya is good. Then internally we have to consider some antiseptic action bearing drugs also we have to consider. Lothra Seviadi, Amrudra, Tikta, Gobihanati. Like that. Usually in OPD I give some bioges like patent drugs also. Then pompholics is also palmoplantar eczema is also very rarely will appear in our OPDs. Okay, is this hydrotic eczema, acute vesicular dermatitis of the hand, there will be sepia itching also. Okay, so intense pruritus, firm deep-seated vesicles. Okay. So sago green or tapioca-like lesions will be there, and there is in some cases associated with atopic dermatitis also there. Most of the time, these if the complaints are severe, Visalon-like medicines also may be required. Here usually now in my practice I give some Vishara drug like Georasha, Taranavasana like or Vishavilyadi and special Dushivishari like yogas which is mentioned in Kriya Kaumudi etc. This one Pampholic appeared in my OPD. That's regarding eczemas. Now we can discuss papillosquamous lichen planus psoriasis. Hello, Shazil, doctor. Hello.
Sir.
Continue ചെയ്യാലോ
yes sir. ഇനി എത്ര മണി?
ഇനി ഒരു അരമണിക്കൂർ.
Okay.
അതോ ഇനി കുറയ്ക്കണോ?
ഒന്ന് ഇച്ചിരി കൺസൈസ് ചെയ്ത.
Okay. ഒരു 10 മിനിറ്റ് കൊണ്ട് ആക്കാം. Okay, so lichen planus, we all know. There are some features. These are mentioned: polygonal, planar, plainly, pruritus. So the important thing we have to keep, for DD, differential diagnosis, we have to watch for these victim striae. Victim striae if present, we can consider. We can very well diagnose that. Okay, lichen planus. Victim striae we can see in this lesion, in that hand lesion, whitish hue, that is victim striae, and in buccal cavity there will be whitish net-like lesions will be there, that becomes there. Then corneal phenomenon in psoriasis and all same features will be there. In scratches, in if any trauma is there, lesion will be appearing there also. Okay, so here in histopathology there will be hyperkeratosis, hypergranulosis. Okay, these things are very important. Here is lichen planus, lichen amyloidus. This picture. This one is lichen simplus chronicus. Then actinic lichen planus is there. Actinic lichen planus. This boy came to my OPD. Now what happens is here the lesion will be annular and the lesion will be aggravating by exposure with sunlight. Okay. The lichen planus pigmentosus is there. Okay, here also victim striae we can see, white hue we can see. Okay, if any patient is complaining with hyperpigmentation or dark pigmentation, we should keep in mind signs of lichen planus also. So in DD we have to keep in mind victim striae presence in oral mucosa. In almost more than 80% of cases there will be oral mucosa involvement. Then nail changes, in severe cases there will be pterygium, thinning of the nail plate and pterygium will be there. Then hair changes also, scarring, alopecia will be there.
Excuse me sir.
So these, hello.
Sir, now this one meeting will be cut. So I am requesting to everyone to join again after cut again through the same link.
Okay. So this can be converted as considered under KIDIBA. So here so many drugs are mentioned in this slide. Actually, in this Nirgundyadi Kashaya, I got good remarkable result in almost all cases. Rasotamadi and Jivdyadi Yamaga combination for establishment. Sir, one short medicine. In my OPD, I am giving for almost all patients along with other medicines. So here in severe cases and all, Shodhana is very important. So many medicines as per several types are mentioned. Plague psoriasis, vulgaris is there. So in all these things, we should check for that erythema. Okay, erythema, thickening, and scale. These will be there in all kind of lesions. Erythema due to new blood vessels, synthesis, and due to thickened epidermis, there will be thickening, and due to faulty epidermal keratinization and exfoliation, there will be scales also. Whereas in inverse or flexural psoriasis, the scales will not be evident. These will be non-scaly and erythematous. And nail psoriasis also will be getting. I mean, most of the time nail psoriasis get into the stage of psoriatic arthropathy also. So here oil drop or salmon patch will be there. Oil like that, resembling lesion translucent discoloration below nail bed. Then nail plate pity will be there. Then white streak called muconegia, splinter hemorrhage. Then subungual hyperkeratosis. Okay, dirty material will be there below nail plate. Then onycholysis. Onycholysis is nail plate separation from nail bed. Then seborrheic is there. Here psoriatic lesion will be there in the seborrheic areas. Then guttate psoriasis is here guttate like cone-shaped lesions will be there. In children and all, usually it will appear after streptococcus or throat. Usually is mentioned as a self-remitting one. Then pustular psoriasis is an emergency. Is generalized is the von Sambush type, annular type, pregnancy induced. Localized is there on palms and soles. Then on nails. Nails. I got few cases in my OPD. It's called acrodermatitis continua. Here lakes of pus or sheets of pus on skin occurs. Okay, von Sambush type. Okay, and severe fever will be there, followed by sterile pustules. Okay, then impetigo herpetiformis, it's von Sambush type in pregnancy. Then erythrodermal psoriasis is there, or erythroderma. Actually, erythroderma is skin lesion is called erythroderma when 90%, more than 90% of the body is involved by that skin lesion. In that case, one case in my IPD without our medicine itself, I got a complete relief few years back. But most of the time it's an emergency condition, so we should opt for allopathic treatment. That also we should keep in mind. Psoriatic arthritis is there. We all know psoriasis modular arthropathy associated with HLA-B27, and it's asymmetric oligoarthritis. Here and distal phalangeal joint and proximal phalangeal joints will be involved, and chance of arthritis mutilans is much more. Okay, due to that much of derangement of joints. Then spondylitis and sacroiliitis will be there. So in psoriatis, we should check for plaintive signs, Grettet test, Van Scandel scales, and Auspitz sign. Okay. And in histology, parakeratosis and acanthosis, then statogranulosis absence, spongiform pustules of Golgi, all these will be evident in histology. Now coming to the vesicular-bullous lesions. In that, severe conditions are pemphigus vulgaris and bullous pemphigoid. So bullous pemphigoid usually will get in our OPD. So here what happens is that desmosomes, that is the binding agent, will collapse. Okay, and in that fluid accumulation will be there. Then bulla will generate. Okay, and as per the site of the lesion. There will be firmness and flaxiness of the lesion. Okay. Histopathologically, there will be subepidermal separation at dermoepidermal junction containing eosinophil and neutrophils. And in Sand sphere is important in the case of pemphigus vulgaris. So pemphigus vulgaris since that Nikolsky sign is positive, there will be this very acute condition, and there is every chance of secondary infection and all. So in that case can be remembered in Kardama VISARPA mentioned in our classes. So here all this can be given by an emergency condition, so we should keep in that mind. It is a bullous pemphigoid visited in OPD. Already, taken Vislon, methotrexate, all these things, they all be taken. The history is there, but he was not getting that much related with the allopathic medicines, and he was getting recurrent bullae and pain and itching. So he consulted me, and with our medication, he got good relief in all complaints. In these cases, we can consider Durva Sarasa internally, then Yashti Kashaya, and Nimbapatra Sarasa for sponging, Panjalkari Kashaya, Nalpavara Kashaya for sponging, etc. Now, we can consider some pigmentary disorders also. After this slide, we can conclude today's session. So, in pigmented disorders, portions coming are vitiligo or leukoderma, which is post-inflammatory. Leukoderma is post-inflammatory. Then pityriasis alba and melasma. So, this one is demarcated in vitiligo. And here, the below one is a leukoderma case. So here it can be compared under Shitra. Okay. Here we can give some Uttejaga Pitagabara drugs. Okay, so Padalamula, like then Chitragasa is mentioned in Chitraprayana itself. Kumariasa, Vilyadi, Bhagji Praga is good. So here what we have to do is that sunbath is very beneficial. And in some cases we can administer prachana. Prachana is also very good. Okay, for that we can, if we are familiar, we can use some Chinese acupuncture treatment also we can use. In needle also we can use. Okay. If lips if involved, usually I give Rakta Chandana, Avagulija Kayoni in a combination. Okay. In patients also taking Kayoni means Bragaraja. Bragaraja internally in food is also very good. Then Pibaldism is there. Here what happens is white forelock will be there. Then some hyperpigmentation will be there in frontal forehead with normal this patient. Then pityriasis alba is seen in patient. Actually, it's patient in patient whose allergic is there, allergic history is there. So it's a part of atopy. So seen mostly in children and young adult, dry, fine scale hypopigmented macules on face. Okay. Here, what we have to do, Rasadushti, we have to consider Rasadushti and Krimigna medicines we have to do. Okay, in those patients having AEC are much more, absolutely is not much more. If you are giving some Krimigna medicines, we can drastic change we can make, drastic decrease in AEC and all. Okay. Then melasma also will be getting very common in our OPD. Actually, we all know is will be happening in ladies, those in menopause stage or those taking contraceptive regimen or during pregnancy. So it's strictly cosmetic issue. So if a blue lesion happening in our OPD, then we have to consider congenital lesions like Mongolian spot neosis, photoneosis, blue nevus, etc. Then, lichen planus pigmentosus, seen in our previous slide. Then, ashy dermatosis, ecchymosis, etc. Then, fixed drug rash. Fixed drug rash. The peculiarity is that lesion will be recurrent, and then lesion will be coming on the same area. Then, post-inflammatory hyperpigmentation. And in our classics, criteria are mentioned. Then, mostly in considering as a rather predominant disease, so here Drashadi, Manjishtadi, like that are beneficial. Regional Churnam, August Terasana, like that also we can give. And some yogas for Western application are also mentioned in this slide. So in our general practice, we should keep in mind some life-threatening dermatology conditions are also there, like pemphigus vulgaris, Stevens syndrome, 10 staphylococcal scalded skin syndrome, then exfoliative erythroderma. Okay, in these cases, we should not take chances. So that thing also we should keep in mind. So concludingly, we all know that dermatology is one of the thrust area of Ayurvedic treatment. and diagnosis is also of the lesion is very important for a good patient interaction for assessing the severity and prognosis of the lesion. And awareness of the common dermatological disorders and Ayurvedic approach is the need of the hour. And Dosha Viparita approach is more ideal than Vyadhi Viparita. So by this, I am concluding my session. Thank you for your kind listening. Thank
you. Okay, sir. Sir, we will go to the doubts session. The first one is one Dr. Nasiba is asked that I will read the question, sir.
Okay.
How can differentiate the white spot due to CRUMI or PITYRIASIS alba in children?
Due to CRUMI or
PITYRIASIS alba.
No, it's not like that. Actually, PITYRIASIS alba is due to some atopy. Okay. Previously, we were thinking that many rosacea, due to this rosacea only this is happening. Actually, in our clinical practice, what happens is these Krimihara management, Krimihara drug is beneficial for all kind of allergic manifestation for atopy and all. That is evident in, as I already mentioned in my slide, in some patients, having atopy, PITYRIASIS alba and all, absolute eosinophil count will be much more. Okay, in those patients, if you are giving some Krivigna-Vadi and Krimihara drugs and all, it will give good result. Okay, due to that is in the treatment of PITYRIASIS alba, Krimigna drugs are already included. We should include. Okay, that in PITYRIASIS alba cases, what happens is we should employ Krimigna drugs for correcting that recessibility. Along with that, we have have to address that allergic condition also, because atopy is the main cause for PITYRIASIS alba. So Krimigna drugs also we have to do. Due to Krimi only, like that manifestation, that we can't say, but we can say that in due to Krimi, in as per our science also, so many respiratory manifestations will be there due to Krimi. So in those patients, in those children having respiratory manifestation, means we should give some Krimigna drug also in that patient. So there is no need of differentiating PITYRIASIS alba and CRUMI. Those patients appearing in OPD having hypopigmented lesion on face, there is no need of differentiating between CRUMI and PITYRIASIS alba, but there is need to differentiate between PITYRIASIS versicolor and PITYRIASIS alba. That's why I showed in my slide some DD of facial patches, hypopigmented patches. I think it is clear.
There another question is what are the general pathya and abhatyas for a skin disease?
Actually, in whole skin disease, when we have to follow that, we have to instruct the patient to follow the pathya strictly when that skin disease aggravates. Okay, when the disease is is not that much severe, we can give him some some kind of glucose we can give, no problem. Actually, all inflammation causing pitta kapha increasing food items and vihara, we should advise them to avoid. Okay, so in those causing inflammation in our body include amla rasa. Okay, so sour fruits and sour vegetables, lemon, etc., we should tell them to completely avoid. Okay, then this junk food we should tell them to completely avoid. Okay, then that bakery items we should tell them to avoid. In the vegetables, that brinjal, then potato, then dried what we called dried mulaga, all these things. Then capsicum. I mean, you should tell them that to strictly avoid this brinjal, potato, capsicum, I mean dried, molaga, all these things we should avoid them to strictly avoid during the, especially during the acute stages. Then advise them as Padya to take 2 to 3 liters of water every day. That also is possible with some chariba or with some dry ginger like that. Okay, some pana also usually in my OPD, if possible, I am giving some shadangam. Okay, shadangam for drinking along with or kashaya and all. So we should give some medicated water also for them. Then avoiding fish and red meat. Red meat is very important. We should advise them to avoid completely red meat. In the case of fish also, some fatty fishes are good, but we can't take risks. So better to avoid fish also during the acute stages. Okay. Then medication and all is very important, especially pranayama medication, etc. are very important in the case of psoriasis, lichen planus, etc. diseases. That is very important. Then milk and milk products also is better to avoid. Then those containing idli, dosha, because that's our what do you call it? These are sour in taste. That also in acute state, that also better to avoid. Then curds, our usual, but they also should be followed. So these things usually I advise.
Okay, sir.
I think it is clear.
One more question is there. Sir, due to calcium deficiency, also the white spots will be occur. So how will be the treatment?
Calcium deficiency, I don't think that it will create any white spot on body. Okay, so due to actually I already told you, these things, krimihara chikitsa, rasa chikitsa, that always we have to incorporate, and some anti-allergic things. Okay, medicines. So in these white spot, if by proper history itself, we should we will be able to know that if any atopy is there in that family. Okay, if atopy is not there in that family, and if the lesions are not due to conditions like PITYRIASIS, versicolor, or indeterminate Hansen's like that features is not there, then we can go for we can go for Pandu chikitsa, we can definitely Pandu krimihara treatment, we can definitely go for. Okay, so these things by history, by clear history, only we can identify what is the what medicine we can do like that. Okay, so it actually emphasizes the importance of taking history, clear history. I think it is clear.
Sir, one more question is there. For mosquito bite allergy, can apply Eladi Thailam?
Can be. Eladi Thailam can be applied. And some other options, some Pittahara, if you are giving, that will be better. Okay, like Panjwalkadi Amagam, Dinesh Valyadi, that will be better. Even Shadava will be better, because in our classic also in Kidavisha, that Nalpamara Siddha Shira, Shiriusha Siddha Shira is mentioned. Shiriusha Srda Shira and Grida is mentioned for treatment. Okay, so considering that aspect, we can go for Shadavada Grida, like formulations we can go for. That will be better compared to Eladi, I think.